Hello, welcome to our final webinar in our first round of technical webinars on the fundamentals of substance use prevention. I'm Laura Papard. I'm the Deputy Director for Treatment and Prevention at the Washington-Baltimore High Intensity Drug Trafficking Area. I also have the pleasure of serving as the Director of ADAPT, which stands for Division for Advancing Prevention and Treatment. ADAPT is a division in the Center for Drug Policy and Prevention at the University of Baltimore, and we're funded to be the technical assistance and training entity for HIDA prevention with substance use across the nation. So we've got about 33 HIDAs in the United States, and all of them are operating in some way, shape, or form, some element of substance use prevention programming, and so we provide support to operationalize our prevention strategy at large for HIDA. We are excited to be here today because this is our eighth technical webinar. It's really rounding out and coming full circle. We have the same presenter that we launched the webinar series with and are very excited to really bring to light the full scope of what we've been discovering and speaking to across the spectrum of concepts. We have really looked at program planning, evaluation, developing a logic model, and a lot of skill-based technical webinars have been embedded in this series. Cost-benefit analysis, even some pretty sophisticated concepts we've tried to break down into relatable and digestible ways for all of you. But then we've also covered some more general concepts like risk factors and protective factors, and all in the spirit of really laying a foundation an essential understanding of what substance use prevention is for our HIDA communities. Today, we have an opportunity to round that out with the topic, what works and what doesn't work in substance use prevention. And it's a way of getting a little more concrete, bringing a lot of these concepts to light, and leaving you with a very direct impression of, within this field, what is working and what's not with our existing literature base, but then also a larger context of when we consider experiential elements, contextual evidence, how that informs one's decision-making process when selecting a strategy for substance use prevention. Just want to conclude very quickly that a lot of us are involved in programs that address specific risk factors or address protective factors, may not specifically be measuring substance use at the end, or may be. And so Dr. Robert Lachos, our presenter today, is going to talk us through that a little bit more and really help us understand how we can think about and language we can use related to speaking to what works and what doesn't in substance use prevention. I want to give a final thank you to Dr. Diana Fishbein, who is with the National Prevention Science Coalition to Improve Lives. She has helped secure all of these subject matter experts in this first round of technical webinars. I also want to thank Patty Versazidis, who is our Assistant Director for ADAPT and coordinating this round as well. Patty, I'll hand it over to you.
Thank you, Laura. Welcome, everybody. Just before we get started, I wanted to give you a few pointers on how you can maximally participate and benefit from today's webinar experience. First, we're really hoping that you will engage through our Q&A discussions. The way to do that is going to be through the the Q&A Ask a Question box that should be directly beneath my image on your screen. So feel free to send questions along the way, and then we'll have a couple of polls that we'll put out. We'll ask you to type in your responses directly into that Ask a Question box as well, hit submit, and then we'll go over those. Also, you all will be receiving a follow-up email at the end of today's event that will include links from today's webinar. At the end of the webinar, we'll also have a survey that will automatically pop up. That'll be your opportunity to evaluate what worked really well with this particular webinar and what might be some ongoing opportunities and needs as it relates to this topic for you. So we really appreciate taking a couple minutes to complete that for us. If you need any technical support today, feel free to contact us at ADAPT or the GoToWebcast information number that is on your screen. So it's my honor to now present Dr. Robert Lachos. Dr. Lachos is a professor of public health at California Baptist University. He teaches both undergraduate and graduate courses in health behavior, research methods, statistics, and program evaluation. His research interests, not surprisingly, are in the areas of alcohol and drug prevention, teen pregnancy prevention, adolescent development, and parent-child relationships. His research has been funded by many institutions, including the United States Department of Health and Human Services, NIH, and the CDC. His research has been published in journals including Journal of Adolescent Health, American Journal of Public Health, Promotion Practice, and at the Journal of Immigrant Health. He currently directs the Prevention Research and Program Evaluation Lab at California Baptist, where he has a SAMHSA-funded drug-free communities grant focused on decreasing opioid deaths through a first responder naloxone training program and countering pro-marijuana influences to reduce youth access in Southern California. Dr. Lachos is also on the board of directors for the National Prevention Science Coalition to Improve Lives, the board of directors for the American Public Health Association, and serves as a faculty mentor for the Diverse Institute's Drug Abuse Research Training Program for NIDA. We're very excited to have him join us here today and to share his expertise with you all. Welcome, Dr. Lachos.
Well, thank you, Patty. Thank you for that wonderful introduction. What I want to first do is talk about what we're going to be able to get out of this presentation. And I think it's my hope that you'll be able to understand what we mean by evidence, both research, contextual, and experiential evidence, and how that may influence your decision-making process in terms of identifying and selecting a particular approach or even a particular intervention. I also think it's important for us to cover what works and what doesn't work in specific types of approaches and programs. So I hope you'll take with you an understanding of at least one effective and one ineffective approach to substance use prevention. And then finally, I think it's also important that we examine kind of the characteristics of these programs and what makes programs overall effective or ineffective. And what I'd like to challenge you to do by the end of this webinar, and as you carry it forward to the next couple of days and weeks and months in your work, is think about how you could take one thing you learned today and apply that to your own program so that you can reach the outcomes that you're interested in. Now, I think a good place to start is just simply by looking at, well, what do we mean by effective? And in the public health and prevention world, when we talk about effectiveness or use the term effective, we're talking about producing the result that we intend to produce or that we want to produce. And in general, we talk about a program being effective if it somehow affects what we call its criteria of merit. That is, what is the program supposed to do? And as it relates to substance use prevention, I think we could all agree we're trying to keep people from starting to use alcohol, tobacco, or other drugs, or what we call ATOD, or if they're currently using alcohol, tobacco, or other drugs, reduce the frequency of that particular use. Now, the reason we talk about behaviors as kind of being the goal that we're trying to get at is because it's the behaviors that cause people to get sick and die. And in some cases, people may say, well, my program that I'm using to prevent substance use was never meant to change people's behavior. We're always trying to increase their knowledge, or maybe we're trying to change their perceptions, or even we're trying to change the way that they feel. And my response might be, to what extent, right? And we also know that the reason why people get sick and die is because of their behavior, not necessarily because of what they know or how they feel or other psychosocial factors. So it's very important, and we'll see this a little bit later on, that we're looking at the behaviors because that's really the public health threat. The public health threat is not that people don't know that, let's say, many people are dying of opioid overdose. The public health threat is people are using opioids, and many of those people are overdosing on those opioids. I also think it's important for us to take the time and think about what do we mean by evidence. So we have a lot of phrases out in the prevention and public health world, evidence-based interventions or EBIs, evidence-informed interventions, promising interventions. So what do we mean by evidence? Well, I think we can kind of conceptualize evidence using the Putty and Wilkins, or what's commonly known as the CDC kind of guidelines for thinking about evidence. And in their framework, they talk about three different types of evidence. The first type of evidence is, well, what do we know from research studies or program evaluations that have been conducted on that particular approach or that program? And when we're looking at that research evidence, we're looking at, well, what was the quality of the study being conducted? We're looking at how many studies were conducted. So if you have one study that was very well done, a very rigorous study, that may not necessarily get as close to the truth about whether or not that approach or intervention, in fact, was effective. So we want to look at replication. Was that study or that program findings, were those replicated in a second, a third, or fourth, or even a fifth study? So the kind of that first part of that framework is, well, what does the research evidence or the scientific evidence say? But there are other sources of evidence that I think are also important as we think about implementing programs that will work. Another source would be contextual evidence. So we may have a program that we know in the scientific literature is likely to reduce the likelihood kids ever start taking drugs. But one thing we may want to ask is, well, would that program work in our community? Would that program, let's say, that was initially studied in a school-based implementation, would that work in a community-based or after-school implementation of that program? If the program was originally studied with a majority of Caucasian youth, would that program be likely to be effective with a population of kids that are primarily minority youth? I also think it's important to think about, when we think about the context evidence, is thinking about, do we have the capacity? Does your staff or your community have the capacity to implement that particular program with fidelity? And in implementation fidelity, or I'll just say fidelity, what that means is, are we implementing the program as it was intended to be implemented, right? So for example, when we go see our physician and we have an ear infection, they might prescribe us antibiotics, and they might say, take these antibiotics 3 times a day for 10 days or till the bottle's empty. But if we only take those antibiotics for, let's say, 3 days and we start to feel better, what might happen is we might not ever alleviate that infection because we're not taking that medication as prescribed. So when we talk about contextual evidence, I also think it's important to ask the question, can we implement that program with fidelity in our particular community? And then finally, as it relates to contextual evidence, I also think it's important to look at, well, what might be some potential adaptations, additions, deletions that we might make, because those all relate to whether or not the program is implemented with fidelity. And then finally, another part of that framework is experiential evidence. And this is the experience that people in the community have regarding drug prevention, or even using a similar program or approach that might be identified and potentially selected. So we might have our own experience that, hey, listen, when you have kids doing worksheets, they typically don't engage. You may have seen that in all of the schools that you're working with, or you might say to yourself, well, it's very, very difficult because of the powers that be in our community to change policies as it relates to, access to synthetic drugs in supermarkets or even tobacco use. And so you might think to yourself, okay, well, based on my own personal experience working in this community, this may or may not be a program that would be successful. So why are these concepts of effectiveness and evidence important? And the reason why they're important is because they directly are related to the president's priorities for drug prevention in the United States moving forward with his administration. And you can see out of the priority areas that are there, 2 of them directly use the term evidence-based prevention efforts. And so it's been very clear for probably the first time in the world of drug prevention in the United States that we need to be implementing evidence-based drug prevention and harm reduction efforts in the work that we're using if we're going to be using federal funds. And I think you're going to see this become more and more prominent over the next couple of years, because there are other laws and policies that Congress have passed that support the use of evidence-based interventions. So, for example, in 2018, Congress passed the Federal Policymaking Act that said that we have to have evidence that our programs are working if we're going to fund them with federal tax dollars. So it's important that you understand, as a person doing prevention in the United States, that using evidence-based interventions are wholeheartedly supported by our federal government. The next thing that I wanted to address is this idea of universal and individual and community level programs. So when we talk about primary, or what we call universal prevention programs, those programs are aimed at everyone. So for example, we assume as, let's say, parents, at some point in our children's lives that they're going to have an opportunity to cross the street. And so what we do as parents and teachers and other people in the community is we prepare kids for crossing a street before even they have that opportunity. So we teach them to look both ways, we teach them to hold hands, we teach them to use a crosswalk. That's the same way with substance use prevention. We assume that all individuals at some point in their life are going to have an opportunity to use alcohol, tobacco, and other drugs. So when we talk about universal prevention or primary prevention, we're talking about preventing alcohol, tobacco, and other drug use among everybody. We can also break that out to individual level approaches and community level approaches. And so individual level approaches are typically approaches that are done in schools or in a classroom type setting, or even in an after school program, where a community level program might focus on more distal factors that are related into the social ecological model. So these would be things like changes in community norms, changes in family structure or parenting. They might be changes in policies or laws in that community that can either promote or inhibit the likelihood that people would use alcohol, tobacco, and other drugs. Now, when we talk about what works and what doesn't work, what I want to make very clear is we know some things. And I've been involved in alcohol, tobacco, and other drug use prevention for approximately 25 years. And in the past 25 years, our understanding of what works and what does not work has been accelerated. But we do find that there's a gap between what we know works in the scientific evidence and what is provided by practitioners in communities to children and their families. We also know that we have to keep doing research to find out whether new or innovative approaches might be effective. But overall, this is kind of what we know. Overall, we know that when we look at the landscape of all substance use prevention programs, the overwhelming majority of approaches and individual interventions are not effective. In fact, when we look at a meta-analysis of over 288 specific programs that were done between 1990 and 2009, we find that only 11% of them were effective. That is, they were able either to reduce the likelihood that people would start using drugs, or they would reduce the frequency at which they were using alcohol, tobacco, or other drugs. Now, another 16% were identified as promising programs. That is, they did show some changes in those important behavioral outcomes, but perhaps the research design or understanding of the context or how the program was implemented was just not clear in the research study in order for us to say, well, we know for a fact that's an effective program. But what's important to understand is that there were 73% of those programs that could demonstrate no changes in any of the outcomes related to alcohol, tobacco, and other drug prevention. And it's not just in prevention that we see this. We see this in drug interdiction type programs, where we see a number of different approaches like DUI checkpoints, individual drug stings. Those types of things are not typically effective. And we also see that even when we look at treatment particularly treatment related to opioid users, where we see the overwhelming majority of approaches are not effective. The reason that I want to show that to you is because I think we often have in the prevention world this idea if that we do something to prevent alcohol, tobacco, and other drug use, it's likely to be effective. And the data simply does not support that. What the data shows us is that most of our interventions and approaches are not likely to be effective. Now, that's not to say that we don't know what works, and we're going to explore that in a moment. So let's first start off by looking at what we know doesn't work in different types of approaches to preventing substance use. One approach that we know doesn't work is biomedical approaches. These are the types of approaches where we tell people facts about how drugs, alcohol, tobacco, and other drugs affect their body, how it might affect their brain, and even how it might affect the likelihood that they might get sick and die. And we've known for a long time that biomedical approaches are not effective. People may know how, let's say, a particular drug like ecstasy affects brain cells and brain functioning, but that doesn't necessarily translate to whether or not they would be able to refute peer pressure to use drugs. And similarly, we also know that informational approaches that are knowledge-based interventions that talk about the consequences of alcohol, tobacco, and other drug use, we know that these approaches are not effective. And I think you might see this in your own life. If I was to ask you, well, in the last 2 weeks, how many of the participants in this webinar have driven over the speed limit in their community? I would say maybe 80, 85% of you have said, yeah, I've driven over the speed limit. But we all know that we should not drive over the speed limit. In fact, there are reminders every mile or so on the highway or the roadway of how fast we should drive, but we do it anyways. And what we know from the psychological literature is that our knowledge has little to do with our behavior, and that's particularly true with our health behavior. Little of what we do in terms of exercise, eating, whether or not we use alcohol, how often we use drugs, has to do with our knowledge regarding the consequences of how those drugs or those behaviors would affect our health status. So we've known for a very long time that informational approaches or knowledge-based interventions are not necessarily effective. I would also add that I conducted a study back in the early 2000s where we looked at a drug enforcement agency, FBI program that was done here in Southern California, where they had shown kids different types of drugs. So they'd even brought in real street drugs, like real methamphetamine. And I remember when I observed one of the lessons that the law enforcement officials were doing is they were actually showing kids like what good quality methamphetamine looks like versus poor methamphetamine. They actually had this on this poster board. And when we evaluated this through a randomized control program, we found that there were no differences in the drug use behaviors or drug use initiation between the kids that had gone through this program and the kids that didn't go through the program. The only thing that we did find is that the kids that went through the program, they were more likely to identify whether or not a particular drug was a quality drug. And they're also able to identify the cost of that particular drug. So the conclusions of that study was it doesn't keep kids, that particular approach doesn't keep kids from using drugs, but it does make better drug consumers. And that's certainly an unintended negative side effect. Another approach that's not likely to be effective, but is very popular, is doing a guest speaker or some type of an assembly. We often see these in K through 12 schools. We also might see them at churches. We could see them community-based agencies, things like that. A lot of times when these guest speakers come in, they might have a powerful story. They have a personal testimony that's even really engaging, but that's not going to change people's behavior. From a developmental perspective, young people see this assembly or this guest speaker showing that if they're used drugs, well, they can get over using drugs as well. And there's not these harmful consequences of using drugs. Also, what's happening in these particular assemblies or guest speakers is they're not affecting the risk and protective factors that are known to affect whether or not people use alcohol, tobacco, and other drugs. These are things like ease of access of illegal drugs in the community, or even things like kids' confidence that they can refute peer pressure to use drugs. I also think one of the things that happens is these types of testimonials of former or recovering substance users can inadvertently promote substance use by glamorizing the dangers that are faced when they were still a user. And so what can happen is, in general, particularly with teenagers, their brains are such that they are risk takers. And that portion of their brain that deals with judgment and decision-making and perception of risk is immature, even up until 22 to 25 years of age. And so when kids see this, they'll say to themselves, oh, this is a way that I can take risks, which is developmentally appropriate for that particular age group, but probably in a way that we wouldn't want them to by taking alcohol, tobacco, or other drugs. Scare tactics was a common approach, and we still see these occurring, where the idea is if kids were scared of using alcohol, tobacco, or their drugs, or even adults knew that, let's say, using heroin or using marijuana edibles can lead to overdose, that they would be less likely to use alcohol, tobacco, and other drugs. And this simply isn't true. So when we have things like testimonies that are kind of what we call fear appeal strategies that try to influence people's behavior by making them scare, what we know is those actually backfire and will actually increase the likelihood that people will use alcohol, tobacco, and other drugs. And we know this from Carl Bem's reactance theory. That is, when people get into a psychological state that creates lots of anxiety, they're not likely to adopt pro-health behaviors. What they will do is they might actually use these drugs to restore their liberty and freedom, or at least their sense of liberty and freedom, and actually do the behavior that's being prohibited. And so what we see this particularly with youth, where if we tell them, let's say, you shouldn't use drugs because these are the consequences, and we show them and we put them in a state where it increases their anxiety, they will actually use alcohol, tobacco, and other drugs to decrease that anxiety, self-medicate for lack of a better term. And so we don't want to use scare tactics, because out of all of these approaches, the scare tactics are probably most likely to have that boomerang effect and actually increase the likelihood kids would use alcohol, tobacco, and other drugs. Similarly, when we have dramatizations like the ever popular Every 15 Minutes program that's designed to decrease the likelihood that teenagers and college students would drive under the influence, these programs have never been able to demonstrate effectiveness. And when we look at those studies that have been done on these kind of dramatization types programs, particularly the Every 15 Minutes program, not only do we find that they don't actually affect whether or not kids will drink alcohol or even drive under the influence, what we do find is that once that kind of emotional reaction to this dramatization wears off, again, it increases their anxiety, and it might make them more likely to use alcohol, tobacco, and other drugs. And then finally, what we call affective-only types of approaches. These affective-only approaches are programs that try to change the way people feel about themselves. So, for example, in the late 1980s, early 1990s, there were a lot of approaches to try to decrease substance use in teenagers by increasing their self-esteem. And when we look at the research on that, we show that there's really a lack of evidence that suggests that approaches that try to change kids' self-esteem are effective. And self-esteem strategies have generally failed for two main reasons. One, it's very difficult to change adolescent self-esteem. And at the same time, we know that self-esteem takes a predictable developmental course. So we know that from like age 7, 8, 9, 10, 11, 12, all the way up into adolescence, that there's a predictable course that happens with self-esteem. But the more important thing is that there's very little evidence to suggest that the reason why kids take drugs is because they have low self-esteem. In fact, there have been several studies that have shown that kids that experiment with alcohol, tobacco, and other drugs actually have high self-esteem. And so when we look at this in my studies, we don't really see a difference between low self-esteem and high self-esteem adolescents and the likelihood that they would use alcohol, tobacco, and other drugs. So we know what doesn't work. Let's turn our attention now to what does work in substance use prevention. One approach that we know is highly effective in reducing the likelihood that kids will use drugs or reduce the frequency at which kids or adults will use drugs is if they have the skills that they can employ when faced with a drug-using situations. So, for example, we know one approach that will work is if we can give kids various skills that they can employ when they're away from home, away from school, they're at a party, they're at a friend's house, they're at the mall with their friends, skills that they can employ to reduce the likelihood they would use drugs. So, for example, refusal skills, the ability to look at the problem, look the person in the eye, state what the problem is, a set of skills that they've learned and practiced so that when they're faced with that risk situation, they'll be less likely to use alcohol, tobacco, and other drugs. Similarly, those approaches that give people, particularly adolescents, the time to practice these skills, decision-making skills, assertive communication skills, refusal skills, identifying and managing, escaping a risk situation. When kids have the opportunity to practice those skills, or college students have the opportunity to practice those skills and get feedback from a trained facilitator, they're more likely to develop a high level of use of those skills and more likely to use those skills in their everyday life. Another approach that we know is highly effective is increasing parent-child monitoring. Now, in 25 years of my research on adolescent drug use, we find that with adolescents, the best predictor of whether that teen will use alcohol, tobacco, and other drugs is the extent to which one or more of their parents are effective monitors of their behavior. And when we talk about parental monitoring, we typically define that as parental knowledge of their adolescent child's whereabouts, associations, and associations and activities. So where they go, what they're doing, and who they're doing that with. And when we look at parents that have low parental monitoring skills and low parent knowledge, or what we call monitoring relevant knowledge, they have kids that are almost 4 times more likely to use alcohol, tobacco, and other drugs. But when we look at parents that have a high level of parental monitoring, those kids are significantly less likely to use drugs. So those approaches that train parents on how to be more effective monitors of their child's behavior are going to be more successful, particularly in reducing adolescent drug use. Now, as it relates for more community level approaches, one of the things we see is when programs move beyond just individual programs like teaching youth about how to use assertive communication skills, or maybe even teaching parents how to be better parents, but they take on a socio-ecological approach where they have maybe an intervention at the individual level. Perhaps they want to increase kids' self-efficacy or their confidence to refute pressures to use drugs. They also might be doing something at the family level, that is a parent training type program, but they're also doing something at the relationship, or what I'll call the peer level, the school level, and the community level. So these are things like encouraging kids to have opportunities to be involved in positive after-school activities, increasing their sense of school connectedness, or what we call school pride. And then obviously at the community level, maybe trying to reduce access to alcohol, tobacco, and other drugs by enacting strong laws and policies that can keep kids from accessing using drugs, or even adults from using drugs. And so we find that these sociological approaches, although they're difficult to do with a great deal of fidelity, when we focus both on the individual and then the family and peer levels, as well as the community and school levels, we find that those programs are highly, highly effective. And then finally, counter-advertising approaches, as it might relate to a community approach, where we're trying to counter the message that pro-tobacco influences or pro-drug influences are trying to convey. So I know in my state where I live, we legalized marijuana several years ago, and there are a number of billboards along the highways and freeways here that all talk about, where to get the best marijuana, when the marijuana dispensary is open. There's a lot of pro-marijuana advertising that's going on. And we need to counter that by giving people the other side of the story. So, for example, there's a lot of messaging that's going on in Colorado that talks about, the benefits of legalized marijuana, both to the economy, health-wise even, so on and so forth. And they're not showing the other side of that. So an example, this billboard says, hey, listen, there's been an increase in traffic-related fatalities as it relates to, legalizing marijuana in California. So these counter-advertising approaches can also change people's perception of the norm, like what's normal to do or what's normal happening out in the world. Okay, Patty, before we move on to the next section, what I'd like to do is ask the participants our first kind of question, and that is, what one thing has surprised you so far about what you've learned?
All right, that question has just gone out to the audience. As you see that question come in, we're going to ask that you type your response into the Ask a Question box. So that's our typical Q&A box. But if you could just enter in your response there and then hit send, we'll go ahead and synthesize those. While folks are doing that, did we want to take just a couple of minutes to look at a few of the questions that have come in?
There's one that has come in that might be pretty quick. We had a viewer ask if any of the methods that you have mentioned so far, Dr. Lachos, work more effectively perhaps with older generation, such as parents or family members, or are they just ineffective for all generations? And that was specifically referring to the slide on what does not work in substance use prevention. Can you speak to that?
Yeah, I think that's a good question. So when we look at like biomedical approaches, knowledge, or what we call information approaches, I think all of that can apply to any age group. I think when we look at scare tactics, we look at guest speakers, as it relates to decreasing the likelihood that people will use drugs, we know those approaches are not likely to work either. There's some reasons why that is occurring, but I think you could say this kind of just covers almost all kind of periods of development, if you will. So, adolescents, young adults, and older people. Now, what I will say is that for very young kids, I would say K through 3, in order for us to be able to get to a point to say, well, you shouldn't use drugs, and here are the refusal skills you need to learn to not use drugs, those kids have to have an understanding that there are certain substances that are harmful and that there are certain substances that are not harmful. But I think what we do is we take that rationale and we take that to high school and we say, well, if these teenagers just knew the consequence of drug use, they wouldn't use that. And that's simply not true. And I always tell people when I do presentations like this, find me a 17-year-old that says marijuana is good for me and I'll give you $100. Now, they may say that, but they're probably lying. So I do think information approaches for very young kids, let's say ages 5 through 7 are appropriate. But after that, I think we can say that these approaches don't work. And I see kind of in the question and answer, people were surprised that guest speakers are not effective. Information approaches are not effective. Some people were talking about how parenting type training is effective. Other people talking about refusal skills as being effective. They were surprised with that. Other people were surprised that knowledge has little to do with our behavior. And those things, you guys are pointing out things that I would say most people that are doing substance use prevention in the United States, these would surprise them. But we've known these things for 25 years. And in fact, we know that there was a study back in 1999, so 22 years ago, that looked at both adults, and these were mainly college students, 18 to 25, and then late adolescents, 17 and 18, 19-year-olds. And they looked at their knowledge regarding alcohol, tobacco, and other drug use to see whether or not it affected their behavior at all. And there was virtually no relationship there at all. I do think as adults, we have this idea that if people just knew something, that they wouldn't participate in that behavior. And I think if we reflect on our own lives, we know that we should do or not do certain things. And we can probably see, if we're honest with ourselves, that we're not doing those things based on our own knowledge. What I'd like to do now is talk about, well, what makes these effective approaches effective? So what are the characteristics of effective substance abuse prevention programs? Well, one characteristic of all these effective approaches is that they all have a clear focus on changing behaviors. They're not in the business of changing people's knowledge, changing the way people feel. They're not necessarily in the business of changing people's perceptions. They're in the business of changing drug use behavior, either decreasing the likelihood that somebody would use alcohol, tobacco, or other drugs, or reducing the frequency of alcohol, tobacco, and other drug use behavior. So the first, I think, and the most important characteristic of effective substance use prevention programs is they're all focused on changing alcohol, tobacco, and other drug use behavior. Another characteristic of effective programs is that they're based on one or more theories or models of behavior change. So in the social sciences, we have several models that tell us, well, why do people change their behavior? What influences them to either not do a behavior or what encourages them to participate in a behavior? And every effective approach or intervention is based on one or more of these existing theories. So for example, one of the most effective middle school and high school interventions for youth called life skills training, developed by Gilbert Votvin, it's based on social cognitive theory, which says that if people have the knowledge on how to do a behavior and they practice doing that behavior, let's say it's assertive communication, and they get good at doing that when they practice, they're more likely to employ that skill in their everyday life. Another characteristic of effective substance use prevention programs is that they focus on learning and practice of drug-resistant skills. So being able to identify, manage, or escape a situation that might lead to drug use. There are things like being able to use assertive communication skills, setting personal goals and objectives. It might be making friends, if we're talking about youth. Not only do people that learn these different skills, but are given the opportunity to practice these with a trained facilitator, those types of programs, what we call these kind of drug-resistant skill programs, those are highly effective, particularly with youth and young adults. Another characteristic of effective substance use prevention programs is that programs that try to enhance protective factors are more likely to be effective. So these are things like helping people learn about what's most important in their life, or building relationships with significant others in their communities. When we try to enhance protective factors in our community, these are things that will cushion or buffer the impact of those factors that would make it more likely that people might use drugs. So what might be an example of that? Well, let's say, for example, you have a teenager that has a very strong, close, positive relationship with an adult outside their family, a coach, a pastor. It could be even some other type of mentor, maybe like in Boy Scouts or Girl Scouts or something like that. That child, because they have that positive relationship, that's going to buffer the impact of, let's say, bullying, or that's going to buffer the impact of school failure and make it less likely that they would use alcohol, tobacco, and other drugs. Another characteristic is when both young people and adults have positive relationships with peers, their children, parents, or other significant adults, those kids are less likely to use drugs, particularly if they have friends that are non-drug using. So we see that when teenagers are able to develop friends and form a peer group, they're much more likely to not use drugs. You see kids that have very poor social skills, kids that don't have the ability to make friends or form a peer group, they're still going to meet that developmental need to make friends and form a peer group. But they're going to be, because they don't have those skills, they're going to be more likely to make friends and form a peer group with kids that are already using drugs. So one of the things we see, particularly with young adolescents, middle schoolers, is they will actually use drugs as an entry into getting into that peer group. So they might be going behind the gym, seeing a bunch of people using, smoking marijuana. They might walk up to that group and say, hey, can I have a hit off that bong? And then now they've entered that peer group. And if they do that over and over again, now they have friends. Kids are going to make friends, just as adults are going to make friends. And if they don't have the skills to have positive relationships with others, they're going to make friends and form a peer group with people that are drug users. And that's the same with adults. And we're seeing some more recent data with men, particularly middle-aged men, ages 35 to 55, where we see increases in drug use that are related to the fact that men don't have quality relationships with other men, or they have few relationships with other men. And so there's been several studies that have come out saying that a good predictor, particularly with tobacco and alcohol use, is the number of friends and the quality of friends that men around the middle age are making or have. And I think we're going to see more research on that in the future. Another characteristic of effective programs is that they tend to use interactive strategies that are designed to personalize and engage participants. So let's first talk about strategies in drug prevention that would not be interactive. This would be where people were listening to somebody talk. They were listening to a speaker, even if that speaker is a teacher, even if they're talking about refusal skills. This would be the case if they were doing some type of game or filling out some type of worksheet or even taking notes. Those are non-interactive strategies. The interactive strategies are where people are out of their seat, they're experiencing that risk situation, and they're practicing skills that they might use in their everyday life to get out of that situation or to manage that situation, so they're not likely to use alcohol, tobacco, and other drugs. So what that might look like in an after-school program at the YMCA is where you might have kids for several days in a row, several lessons in a row, they might be role-playing using refusal skills so that we can build their self-efficacy or their confidence to use those refusal skills, so that a month down the road, a year down the road, when somebody offers them drugs, they'll be more likely to employ those skills. Another characteristic that I think is important to point out that has a much broader type of reach is when communities change their policies or laws. Now, we can think of a community being a school, or we can think of it being a town, or maybe even a county, so that when there are laws or policies that prohibit behavior, they have a drastic reduction in alcohol, tobacco use. Let me give you an example of that. In the 1996, California prohibited smoking in any bar, restaurant, tavern, or gaming facility. So what does that mean? That means when people would go out to eat, they can no longer smoke in that restaurant or bar. And what you saw within 3 years, there was a dramatic reduction from about 42% of adult smoking in California to about 12% smoking, simply because there were fewer places that people could smoke. We see the same thing when we change policies regarding, let's say, marijuana dispensaries. When there are fewer marijuana dispensaries in a community, that means kids and other adults are going to have less access to those. So one thing we know that overall is an approach, particularly at the community level, is when we can change or update or even reinforce new policies or laws in our community. That being said, there is what we call a prevention paradox with community level interventions. That is, these types of approaches are likely to affect far more people than, let's say, lessons on using refusal skills. But the effect they have on any one individual will be much less. We also know that most of these effective programs are socially, developmentally, and they're culturally relevant. So they're relevant to people's developmental stage, whether they're an adult or they're, let's say, a kindergartner. They also are cognizant of people's social world. So a few moments ago, I talked about a very important developmental task in middle school and high school is making friends and forming a peer group. We need to be cognizant of that and how that might relate to alcohol, tobacco, and other drug use. And then finally, they have to be culturally relevant, that we have to understand the values and the morals and the history of different cultures and how that affects disparities or inequities in drug use, or even whether or not certain ethnic or racial groups, would it be appropriate to use assertive communication skills? Would that be appropriate to communicate assertively in that particular ethnic group? So we need to keep that in mind, that these types of programs that are effective, they have that background. They're socially, developmentally, and culturally relevant to the people that are going to be participating in those programs. A very important characteristic, particularly of school-based programs, is they have to have adequate dosage. And what we find in the research is that the most effective programs are at least 12 hours in length. So we look at like a school-based drug prevention program, it needs to be a minimum of 12 hours to learn and practice those skills in some type of interactive lesson that's being done in the school. If you simply come in and do a one-shot assembly, or maybe you have kids do Red Ribbon Week, that's simply not adequate dosage. It needs to be about a minimum of 12 hours. And what we're seeing is that the most effective programs will have an initial 12-hour lesson, and then they will have follow-up booster sessions in the subsequent years. So maybe you're doing the 12-hour Project Alert program in 8th grade, and then in grade 9 and 10, you're doing 2 or 3 booster sessions as well. There has to be adequate dosage, and that needs to be at least 12 hours of instruction. We also know that effective programs provide facilitator training. In order for programs to be effective, you have to give the people implementing the program, or the people that are trying to influence policy change, they have to have the formal training and the experience in that field in order for them to be effective. And one of the issues we have in drug prevention is that anybody can do drug prevention, but the programs that are most likely to be effective, they're using facilitators that are implementing the program, whether it's an individual, like a universal program, or it's a community level program aimed at changing policies and laws. These people employ people with training in public health and the social sciences, and then also have experience doing these types of things. And then finally, a final characteristic of effective ATOD programs is that they evaluate to determine whether or not they're effective. And if they're not effective, they're changing what they're doing. If they find out that kids who go through, let's say, Project Alert are not less likely to use drugs than kids that don't get Project Alert, then maybe they start using a different prevention program. Or if they find out, let's say, for example, some social norm campaign that they have where they're trying to change people's perceptions about drug use norms, if that doesn't have high dosage, like hardly anybody in the community can recall that message that's in that social norms campaign, then maybe we need to increase the dosage of that. So evaluating their programs, we see that the most effective programs do that so that they can continue to improve what they're doing. What I'd like to do now, Patty, if we could, is go ahead and ask the second question.
That question has been sent out to the audience. This is a yes/no question, folks. So if you wouldn't mind just reading the question there and responding yes or no, and then hitting submit.
Dr. Lashos, we have several questions that have come in related to the content you just discussed, as well as previous content. So when you are feeling ready, I'm happy to shoot you some of those questions.
Go ahead.
All right, the first one coming in was related to ACEs and recognizing that many of the original ACEs are associated with unsupportive and harmful parenting, as well as substance use later on. And the general question from this viewer is, should the CDC, should the National Institute for Mental Health and/or other health organizations and agencies be working on perhaps a new kind of parenting education that might reach everyone, everywhere, at all times? What are your thoughts on that?
Well, I first think we need to differentiate between like universal programs and what we call like selective programs. So like universal programs are prevention programs aimed at everyone because we think that everyone's going to be likely to use drugs, or at least have the opportunity to use drugs. Or selective programs, or what we call secondary prevention programs, are aimed at high risk folks. And certainly people that have experienced trauma or are having difficulty parenting or even are recovering addicts themselves might fall into that particular group. In terms of parent training, there was an initiative that started back in the early 2000s to try to increase the parents of teenagers, increase their parental monitoring skills. And it was a huge media campaign. And I showed you one of the posters from that. But as the funding went away, it went away as well. And I think one of the reasons why it went away is because there was actually no training component like the person who's asking the question offered. There was a lot of media that was going on telling parents, hey, stay involved in your kid's life, but there was no training on how do you stay involved in your kid's life. And so that would be something that I would encourage people to explore if they're working in some type of a parenting program, is looking at how can we increase parental monitoring among that group. Other questions?
Thank you. This one relates to having guest speakers and holding those assemblies that you were referencing earlier as being ineffective, right, according to existing literature. This viewer is wondering, they've had some experiences with these assemblies in the past. They felt like they have been impactful in various ways. Wondering if you have any recommendations for what to use in lieu of those assemblies or bringing the speakers in for one-time events.
Yeah, and I think that's a very good question. You know, sometimes we might think that this approaches work, but we have to remember that's our own anecdotal experience, and we're only seeing, you know, that one time, where these studies are looking at hundreds, if not thousands, tens of thousands, and what's the impact on all of these people. So we might perceive for us as adults that that's having an impact on us, but remember, we're not that sixth grader in the audience, and we're not seeing every sixth grader in the United States. There are some specific school-based programs that are available out there in the that are currently evidence-based, and we're going to take a look at some of those in a moment. I think we might have time for one more question.
All right, I'm actually going to try to shoot you two that are very quick. One is, you mentioned and showed an actual visual of the billboard for the counter advertising, right? But you also had mentioned that fear-based or scare tactics were ineffective. Can you reconcile that for the audience? How is counter advertising different from scare tactics or any fear-based methods?
Yeah, that's an excellent question. And I think the fear-based types of approaches, the scare tactics, I think the end result of the people that do those is they want to scare people into changing their behavior. And we know that simply doesn't work in action. It can boomerang. Where counter advertising is more about trying to counter the message that the pro-drug users or pro-drug producers, particularly as it relates to marijuana, are putting out there. So, for example, the billboard we saw was showing that, you know, hey, listen, you know, traffic collisions have increased, where there have been places in Colorado where they've actually said, hey, listen, you know, marijuana is good for you. So I think by telling people that, you know, traffic collisions have increased, I don't think that's scaring people. What I think it's saying is, hey, listen, they're telling you there's one positive thing about legalized marijuana in the state. We're telling you another side of that story. I don't think their intention was to increase anxiety or fear in people to change their behavior. And did you have one more, Laura?
Nope, I'll hold on the rest for now.
Okay. So we've talked a lot about what works and what doesn't work, and we've even explored some of the characteristics of effective substance use prevention programs. So what you might be thinking now is, well, how do you identify and select some of the more effective approaches? So what I'd like to do now is kind of walk you through the process that I use and I train my students on in identifying and selecting an evidence-based intervention. So one thing that we know is that there are a number of online registries, and we're going to explore some of these that are available to us, where we can look up different types of programs based on populations, based on how they're implemented, based on even specific types of alcohol, tobacco, and other drugs. But one of the issues that is challenging with all of these registries is that they're not able to inventory all effective interventions. So a great example of that is Project Alert. Project Alert was developed by the RAND Corporation and Dr. Ellickson over 20 years ago, and it has a number of randomized controlled trials, number of good quasi-experimental design studies, even contextual studies that were done that all show that Project Alert is effective in reducing alcohol, tobacco, and other drug use. But if you were to go look at, I think it's 4 out of the 5 registries that we're going to look at today, that program's simply not there. And there's a number of reasons why that occurs. One reason why that occurs is because each of these registries tend to have their own criteria of how they define what an evidence-based intervention is, the standards for those criteria, as well as even their own rating system. So some of them will have like a 1, 2, 3 rating system. Some of them will have like evidence-based, promising, or ineffective. There's even one that has, 5 stars, 4 stars, 3 stars, 2 stars, 1 star, kind of like the Yelp of evidence-based interventions. They all have their own criteria, all have their own standards, and all have their own rating systems. But there are also some strengths of these registries. One is that if you have internet access, it's easy to get information about these programs. All the registries that we're going to explore today, they tend to list the most important information. So for example, how many lessons the program is, or how the program is implemented. They have information about maybe what theory the program is based on. It has information about the cost of the program, if there is any cost, information how to contact the developers. In many cases, they're transparent about how they've rated that particular program by looking at the outcomes that program was able to achieve, the evidence that was provided in order to give that particular program or approach the rating that they got. So we have to say that there's a lot of advantages of using these registries, but there are also some limitations. Again, not all of these evidence-based interventions are going to be listed on these registries. And another thing is there could be a conflict of interest. Some of these registries are based out of institutions, and they may be biased, or they may be trying to turn a profit. Some of these registries allow people to self-nominate. So you've developed a program, let's say in New Jersey, and you want to get on this list. You can fill out the form yourself. You can put whatever you want in there. And then they say, okay, this is an evidence-based intervention. Where others, you have to go through a more rigorous review process where they're very transparent about the fact, hey, it has to have this type of research design. You have to demonstrate these outcomes with no negative side effects. There needs to be replication. The study needed to have contextual evidence about implementation. It needed to affect different racial and ethnic and gender groups. So the way that they rank these is a limitation that I think we need to consider. I also think it's important that we not just look at the rating that the particular program or approach has obtained. We also need to look at the contextual evidence. And we talked about this before, of looking at, well, the way this program is supposed to be implemented, would that be appropriate for my community? Or maybe you have some experience doing similar programs and you're going to say, you know what, this program simply not going to work. Having kids come on a Saturday to the middle of the city to a 2-hour session is just not going to be conducive to what we're trying to do. There's transportation issues, there's space issues, there's timing issues, things like that. So I think you need to look at the context in which that program is implemented, but you also need to be sensitive and recognize your own personal experience, your own expertise, and asking yourself whether or not this program would be effective in your particular community. Another great way besides these registries is looking at the academic journals, like the Journal of Prevention Research, Health Education Behavior. There's a journal called Drugs, Education, Prevention, and Policy. And there's a number of other journals that every month are reporting on the effectiveness or lack thereof of different substance use prevention and intervention programs and approaches. So you can go and look at these, just a table of contents, and you might find, hey, there was a study or an article or even a review on a particular approach that you might be interested in, and you can learn more about that. And I think when you do that, you're going to get much more timely information about a particular approach, because the registries are going to lag behind by years. In other words, there might be 2 or 3 studies that come out on, let's say, a brand new ABC substance use prevention program for college students. That might come out in the peer-reviewed journal articles over a year time span. None of those interventions will ever make it to a registry for years and years and years. And then a great way to learn more about this is contact experts in the field. Most of us have a local university that's nearby, and find out, well, okay, who's the woman, who's the man that's, kind of an expert there on substance use prevention, and ask them, hey, what do you think of this particular approach? I think that's always very valuable advice. And then finally, you can contact other people in the community and ask them, well, what was your experience with this approach? You tried to create a policy in your town that would decrease the number of marijuana dispensaries. Well, what did you do? What worked? What didn't work? Sometimes you can interact with these people at professional conferences. Other times, you could call them up. I think that's a very, very valuable way to figure out what works and what doesn't work, particularly with specific interventions. Now, we talked about these registries, and there's a number of different registries available out there, including the What Works Clearinghouse, Blueprints, which is out of the University of Colorado, the California Evidence-Based Clearinghouse, which is funded by the California Department of Public Health, and then the Cochrane Collaborative, which is more of an international organization as well. Be very wary, though, of the fact that you'll find lists of different substance use prevention or evidence-based intervention registries are out there, and many of them are no longer available. So, for example, SAMHSA used to support a registry, which back in 2009, they suspended that particular website, so it's no longer there. There's also the Healthy Kids Resource Center. They lost their funding, and that's no longer available. So when you click on some of the links that you might find on the internet where it says this is a place you can find evidence-based interventions, don't be surprised if that website no longer exists. All 4 of these particular registries are still updated regularly, including Blueprints. And so one that I'd like you to walk through with you right now is an example from Blueprints. So if you were to log into Blueprints, you can go to a program search, and you can search by different types of filters, including target population, different substances. You can filter it by maybe whether or not it's a universal program or a community level program or school-based program. There's a number of ways that you can filter it. And in this particular example, I wanted to look at school-based interventions that are designed for high school students, so grades 9 through 12. And what we find here is that there were 3, what they call model programs or model plus. So these, what they are considering effective or evidence-based interventions. And then there's also 12 that, by their criteria and the standards on those criteria, what they consider promising programs. And in general, Blueprints has a promising program where there's some evidence that it affects some risk or protective factor related to drug use, maybe not actual behavior, or it may be the case that the design that they use, the evidence that they're using to say that the program's effective, has bias in it or it's a low quality evidence. Blueprint's has a pretty high threshold. When they say something's a model program, which is their term for an evidence-based intervention, there's a pretty high threshold that's there. And what you can see in this example is that there are only 3 model programs or evidence-based interventions. And that would include the program that would be a model program like the Life Skills Training Program by Gilbert Votvin. There's also another one in there that's called Project Towards No Drug Use. That's done by Steve Sussman out of USC. And then there's another one called Positive Action. Notice there, going back to our slides previously, that there's only 3 school-based programs aimed at high school students that Blueprints has said are evidence-based. Only 3. And so what that kind of means is what Blueprints is saying is like, listen, if you have an ear infection, there are 3 different drugs that we know for a fact are going to cure your ear infection. And then there's these kind of 12 other things that you might want to consider taking, but there's really no evidence that they're effective. And this reflects kind of that meta-analysis we looked at, that most of these drug prevention programs are not effective. And if you were to click on, let's say, Life Skills Training, it'd bring up this fact sheet here, and you can click on that, and it'll show you, okay, what is the program doing in terms of its program outcomes? What type of program is it? What is the setting to which it's implemented? In terms of what we know about evidence, what is the gender, age, race? Where do you contact people if you wanted to use this program? Who's in charge of it? Where can you purchase it or get training on it? Then it provides a brief description of the program. And this is typically taken by Blueprints from the research literature, as well as interviewing people that have used the curriculum, as well as the curriculum developers themselves. It will also break down for you kind of the evidence that they used to support the fact that this is a model or an evidence-based intervention. And they'll actually put the citations there as well. So if you wanted to get more information about that particular study. And so you can see this particular program has a number of studies that have shown that it can make significant reductions in tobacco, alcohol, and other drug use. And then you can also look at other features like what are the risk and protective factors it aims to try to impact, as well as details regarding how the program is to be implemented in different demographic groups, where you can receive training or technical assistance on the program. So for example, in Life Skills Training, it's a commercially available program. In order to purchase the program, you do have to go through training from the developers and their staff. So Blueprints kind of brings this out for you in a nice format. And one of the things I've developed for the participants of this webinar today is an actual worksheet. And we'll make sure that you'll be able to get a copy of this, is a worksheet that you can use so that when you're either looking at Blueprints or the What Works Clearinghouse or any other registry, you have a way to take information about that approach that you're considering adopting and put it in a way that you can analyze whether or not you want to use that particular approach or give that information to someone else. So in this worksheet, you can put in the name of the program. Where did you, get information about this program? Was it Blueprints? You can even put in the URL and hyperlink it. What population does this approach or program target? What setting? Is this a community level program? It's aimed at, a social norms campaign to reduce alcohol use, or is it a after school program for youth? What theory is the program based on? How many components are there? Is there like a policy component? Is there an advocacy component? How is it supposed to be implemented? So context, who implements it? How is it supposed to be implemented? Looking at what are the specific components or strategies that are used? And then another thing that we want to identify is, well, how do we know it's effective? How do we know that it's likely to work? What study tells us that? What were the outcomes of that study? You want to also look at the quality of that evidence. So was it a high quality study that used a randomized controlled trial or quasi-experimental design? Or was that a study that used a one group pre-test, post-test design where we really can't say it was the program? So you want to look at both the strength and the quality of that evidence. And then finally, the last part of that worksheet is where we're looking at, well, what are the contextual factors that would either make the program likely to be effective in our own area, or might be difficult for us to implement and might be difficult for us to achieve our outcomes. So what's going on in the community, the school, the area? Maybe it's just not a right time to do a policy advocacy type program, because maybe you have a brand new city council and your organization doesn't have a lot of relationships with people on that city council. And then I also think we need to identify our own experience. So do we have experience doing school-based programs? Do we understand how schools work? Or maybe this program might be more effective in an after-school program. It might also be to say, okay, this program's not likely to be effective with this age group, or maybe even this literacy group. And then another space to add any other information or comments about that. And, if you could do this for, let's say, 3 or 4 programs or approaches that you're considering adopting, it's a nice way to organize all of this information so that you have a way to say, well, this is why we're going to select this particular program and implement it in our community. And you're able to provide all of that piece of information for any stakeholders that might be interested in that information. If we have time, Patty, can we do the last question? I'm also able to take other questions as well.
Sure. I am sending that last question out to folks right now. Again, this is an open-ended question, so we just ask that you go ahead and type in your response into the Ask a Question box and then hit send. That way we'll be able to see those as they come in. And in the meantime, yes, we can go and do another question.
Okay, so since we are going to have several responses coming in, I'm going to try to get through some of these quickly, Dr. Lachos. Some that you might be able to answer with fairly quick responses here. You mentioned dosage earlier on and then a follow-up with booster sessions. This viewer is wondering, for the 5 to 7-year-old age range, is dosage important? Is that what you were referring to? And is dosage also needed for high school students? So were you applying that across the developmental spectrum within youth, or were you targeting one specific age with that comment?
So when we look at dosage, one of the things that we know is that to begin to affect behavior change, it has to be a minimum of 12 hours of instruction. And that would include younger kids, middle school age kids, high school kids, or even adults. Now, that's the minimum amount. And what we see in the most effective programs like life skills training, and I'm talking about universal programs right now, they're more like 15 or 20-hour programs with booster sessions in subsequent years. So the quick answer is yes. Even at 5th grade, you would, or kindergarten, you'd need to have more than just one session. We often see that those programs that are like 1 week long or like in Red Ribbon Week, where they have all of these activities, if you add up all the amount of time of instruction, it ends up being 3 hours across a week. That's simply not enough to create behavior change.
Okay, one more quick one. Are you aware of any evidence-based strategies that specifically promote positive peer relations?
Yeah, I think one of the things about all 3 of those programs that we were able to look at, Project Towards No Tobacco Use, also the life skills training, both of those programs focus on giving kids skills to develop their social world. So how to make friends, how to maintain relationships. There's a part of a lesson in life skills training where they look at how do you get closer to people, like different types of intimacy. They talk about work intimacy, sport intimacy, all of these things. So many of the effective programs are going to have a component in there that are going to be on building kids' social skills. I've also seen this occur even with adults as well. So, I mean, a universal prevention program with adults. So like, how do you, make friends, or how do you, do those types of things? Because I think that's important for adults as well, because we know that adults that are more isolated, they don't have friends, they're going to be more likely to use substances.
Thank you, Dr. Lachos. The comments coming in for this last question will start on line 57 for you to peruse through. So
we had some people talk about a social norms campaign. that is something that is likely to be effective at the community level. And in social norms campaigns, what we're trying to do is change people's perceptions. I think a better way of saying that is change their misperceptions. So we know that there's a link between what we think is normal to do and what we actually do. And you might be thinking, well, no, I'm my own woman or I'm my own man. I don't do anything that anybody wants me to do. I'm in complete control of my own life. I would ask you that when you get into an elevator, you probably face the door. But why do you face the door? There's no law that says you have to face the door. It's not written in the Bible that you have to face the door of the elevator, but we all face the door of the elevator when we get in an elevator. Why do we do that? It's because we think that's normal to do. And so oftentimes adults have misperceptions about what's normal to do in alcohol, tobacco, and other drugs. So they may think everybody drinks alcohol, or it's appropriate when I go to a restaurant to drink 7 drinks. When in fact, if we show them that that's not the actual norm, if their perception of the norm goes down, their behavior will go down. This has very strong effects, particularly with younger adults. So the social norms campaigns are likely to be effective. I like the fact that people are kind of picking up on the characteristics of effective programs and how they're going to use this particular information as they move forward, including the evidence-based intervention worksheet. So I hope you find that very helpful to you as you move forward. So let's do some concluding thoughts here. One, again, we know that most of our efforts in substance use prevention are not likely to be effective. And in figuring out, identifying, and selecting an evidence-based approach is critical. Because if we start with a program that we already know is not going to work, there's nothing that any one of us as individuals is going to be able to bring to the table to make that program effective. So it's very important that we begin to use evidence-based interventions and approaches. And these approaches do exist. We saw some examples of school-based interventions for youth, looking at blueprints. But there are a number of different registries, including the research literature that we can go to look at what works and what doesn't work. But we do know those things. We do have a pretty good handle on what works and what doesn't work in substance use prevention. We know that the most effective programs for youth are going to teach them the skills that they need when they encounter risk situations to use drugs. These are things like avoiding a risk situation, increasing their personal competence, or even changing their access to drugs in the community. But whatever program that we choose to use, we need to implement that program carefully and with fidelity. And the extent to which we make adaptations or deletions or we make changes to the program is going to correlate to the extent to which that program is going to be effective. We also need to determine whether or not that particular program is effective. Is your program working in your community? And can you prove that it's working? Or is it just your opinion or your perception? So it's important that we evaluate our programs to determine whether or not they're working, and also figure out, well, if they are working, why? If they're not working, how can we make improvements? And when we have good evaluation information, we're more likely to make good program improvements. If we're using bad information in which to make those changes, we're more likely to make poor choices when we make those changes. So I hope you're able to identify one thing that you learned today that will help you improve your substance use prevention work in your community. As always, if you have any questions and I can be of service to anyone, I'm happy to do so. Patty?
Well, since you asked, Dr. Lachos, we do have several questions. I'm going to combine a couple from one particular viewer. He's asking about the Reward and Reminder program as a community-based program. If you're familiar with that, something that researchers can use to promote and maybe change or advance policy and regulations related to substance use. Can you speak to that at all?
I'm not, I am familiar with Reward and Reminder kind of approaches. I don't know about a specific program that's called a Reward and Remind, but if I remember right, these kind of approaches are looking at preventing access to alcohol and drug use. Sometimes there are things where they're doing decoys, attempted purchases, things like that. And let's say a clerk at a gas station cards the kid, then they get some type of, gift card, or in my intervention that I'm doing, we do gift cards and we give little certificates that, hey, they passed the decoy test or whatever. And then also, if they haven't, they do end up doing that. We cite them or we give them a reminder of the law or things like that. Many of those approaches can be effective, but they're only effective to those that actually do that. So if you think about, well, how many of those stores are you really impacting, right? 10 or 20 in your community. I mean, they're very resource intensive. And also, if you look at some of the research on that, is those effects are not long lasting. And there's a couple of reasons why they're not long lasting. One, they're all based on the perception of susceptibility. How likely are you to get caught? And then severity, how bad would it be if you did get caught? And we know that wanes after, let's say, a week or two. The other thing is that a lot of these merchants that typically work at places where you might buy alcohol or even synthetic drug dispensaries or marijuana dispensaries, there's lots and lots of turnover in their employees. So you might have a person that has lots of perceived risk and severity not to sell alcohol to minors, but a week later, there's going to be a brand new person there that has very low perceived risk and susceptibility. I hope I answered that question.
Dr. Lachos, we're wondering, we need to wrap up this particular segment, and if you're available for a few minutes following the 5 o'clock hour here on the East Coast to answer a few more of these questions, that would be wonderful. If not, we can send these to you, and I know that you're always good about replying via email to some of these viewers. Want to thank you personally for being a presenter on 3 of our technical webinars now. I mean, you have just brought loads of insight to this field to us. And so on behalf of ADAPT and the Western Baltimore HIDA, I sincerely thank you for that. I also wanted to announce to the viewers that we are starting a new series tomorrow titled Evidence-Based Practice Spotlights in Substance Use Prevention. And our first webinar will be on the scope of pain, training for healthcare providers that's focused on pain management. We've selected that one because it's a program that's been funded by New England HIDA for some time. But what's kind of neat about this series is we will apply many of the principles that Dr. Lachos discussed today on being able to appraise evidence and really understand it from that framework of research-based as well as contextual and experiential evidence, and putting that all into context based on the studies for that particular strategy. So that will be launched tomorrow, and if you'd like to subscribe or learn more about that, the ADAPT information and ways to connect with ADAPT is located in your resource supplement that you've been able to download under the Event Resources tab. Patty, I'm going to hand it over to you for any final words, but Dr. Lachos, thank you. It's been a pleasure.
You're very welcome.
Thank you again, Dr. Lachos. Folks, we will be sending out to everyone who attended today a link that will include a link to the resource supplement as well as the archived video of this webinar. So if you want to go back and rewatch any components of it, we encourage you to submit any additional questions that you may have to us. We already have the questions that have been submitted, and we'll work to go ahead and get some responses back to you. Whenever the webinar ends, you will see an automatic sort of post survey that will pop up. Please take some time, tell us a little bit more about your experiences with today's event. We really look forward to seeing you at a time in the near future. Wish you all the best. Take care.
Thank you, Patty. All right, Dr. Lachos, we'll go on as long as you've got time, but I think some of these can go fairly quickly. We've got approximately, it looks like 12 to 15 questions that have come in, some just asking specifically about a particular strategy. The first one I'm going to ask you about really relates to something called cooperative learning. And they are asking about this particular strategy can be found on the Crime Solutions website, another repository that rates programs. The cooperative learning as a substance use prevention approach can have hundreds of hours of dosage every year with that particular approach. This seems more likely to generate effects as compared to something that is only 12 hours. Can you speak to that at all?
Dr. Lachos, are you still with us?
Oh, can you hear me?
Yes, we hear you now.
I'm sorry, I think I was on mute. I'm not familiar with a specific program called cooperative learning, but I know of cooperative learning types of programs. It's kind of the same thing with life skills training. That's the name of a particular program, but a lot of programs call themselves life skills programs. So what I know of cooperative learning is kind of a more of a group based approach. They're typically done in schools. They're done with kids that maybe be more vulnerable to peer influence than other kids. And what they're trying to do is teach kids positive social skills. And some of the research on those types of programs have shown that it can decrease stress. It can increase academic engagement, even increase, kids attending to school. But I haven't seen, and I'm not to say it's not there, but I haven't seen any information where it says it's actually changed kids' ATOD behavior.
Thank you, Dr. Lachos. Another question came in around refusal and resistance skills. You talked a lot about that today. The question is around how can those be taught, but maybe you can also offer just some general resources that they can go to get some ideas of programming that integrates refusal and resistance skills training.
Yeah, that's a great question. In all three of those programs that were on Blueprints, so life skills training, Project Towards No Tobacco Use, as well as Project Alert, all of those programs are almost totally focused on building kids' skills. In fact, the Botvin Life Skills Training Program is a 15-lesson program, and there's only one lesson in there, I would say one half of one lesson, where they even address the dangers of drug use. They minimize that kind of information biomedical approach and focus more on skills. So life skills training, Project Alert, Project Towards No Tobacco Use, all are skill-based programs that have demonstrated outcomes.
Thank you. This next question addresses culture and trying to implement prevention strategies in a culture that may not be completely bought into the value of prevention strategies. Can you speak to finding sustainable funding? And it seems like really the question should be more on how do you begin with implementing those particular strategies, but sustainable funding to have ongoing prevention efforts within a community that may not necessarily support it.
Yeah, that's a good question. Well, as it relates to, I think when it relates to like school-based stuff, we have a federal law, and it's been around since 1989. It's the Safe and Drug-Free Schools Act that Congress passed. And that says every public school in the United States has to do drug prevention education and violence prevention at some time when kids are in schools. So all public schools receive funding from the federal government to do that. I think the last time I checked, it was like $9 and some change to do that. So public schools are getting money. The other thing that you can also look at is kind of federal funding that's, through HIDA. SAMHSA has a real strong drug-free communities program with over 700 funded programs throughout the United States. So there's going to be funding that's already available out there. But what I want to emphasize is that it's not likely you're going to be able to get that funding unless, one, you have a logic model and a plan based on an evidence-based intervention, so to where those reviewers can say, yeah, this is likely to be effective. The other thing I'll say is once you start getting a history of saying, listen, we've implemented this program for 5 years, and we are able to demonstrate a 30% reduction in the likelihood kids using marijuana in this particular community. That is what's going to make it more likely for you to receive more funding.
Okay. Are there any effective strategies or any strategies at all out there that address not having a father figure or a role model of some sort in that realm, specifically male related in the family unit? Any programs that or any evidence suggesting that that has an impact or is a risk factor for substance use later on?
I don't think being in a one-parent household is the risk factor, or even specifically not growing up without a father is the risk factor. I think it's more related to it could be economy, it could be family disruption, maybe where you have another person, boyfriend, girlfriend coming in and out of the house. So it's not the fact that they're fatherless, it's the fact of all of these other factors. But what I will say, as a trained developmental psychologist, that's probably not the thing that I would be worried about. In other words, out of all of the risk factors that contribute to alcohol, tobacco, and other drug use, I would say, lack of a father or even a mother is going to be way, 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 way down on the list. And that there are more what we call proximal factors, more influential factors that predict whether kids will use alcohol, tobacco, or other drugs. And I would focus on those.
Thank you. Have you heard of NIJ Crime Solutions? They also cover substance use prevention, in addition to bullying prevention, and are less likely to reject research for inconsequential issues compared to blueprints. Is that a group or an org that you've heard of?
Yeah, the National Institutes of Justice Crime Solutions mainly focuses on restorative justice and delinquency type programs. Sometimes drug prevention programs are linked within those. They tend to be very popular with law enforcement agencies just because that's kind of the world that the law enforcement agencies kind of work in. I do like in that crime solution from OJP is that they have both program kind of what's an evidence-based program, and then they also have practice type things or what I would call approaches. And so I think that's a good resource. It's just limited in terms of specific alcohol, tobacco, and other drug prevention programs or approaches.
All right. Any ideas for older adults, evidence-based strategies for older adults?
Well, honestly, when we look at older adults, and I'll say, older adults, 55 and up, their initiation of drug use is very, very low, the rates of initiation. And what we see in the literature is if you can keep somebody from using alcohol, tobacco, and other drugs till about the age of 25, they're going to be very unlikely to use alcohol, tobacco, and other drugs. So that's what I mean by like universal prevention. Now, if you've got people that are already substance users, right, they're already using drugs and alcohol frequently, or they're substance abusers, that is, they're addicted, that's a different type of an approach. Those are our intervention and treatment particular approaches. It's not likely that a person that's going to wake up at age 60 years of age and say, well, I want to start partying. Usually the reasons why those people are going to start using drugs is because there's some other underlying issue going on. It could be an undiagnosed mental health issue like depression, so they're self-medicating. It could be pain management. It could be something else going on. And that's really where you would need treatment, not prevention.
Okay, and our final question really relates to if anyone wants to be able to reference the what does not work list of items that you provided earlier, will you be able to provide us some citations that we can send out to the viewers to have some type of reference list they can provide in their discussions moving forward?
Yeah, those are actually on the reference page here, and there's links to most of them that are available online. I would encourage people to look at the Sussman article, the Donaldson and Sussman article, and then also another one is the prevention tools, what works, what doesn't, and that's from Washington State Healthcare Authority. Both of those, I think, are very good primers regarding the research base from our discussion today.
Okay, so just to clarify, the list for all of these citations for what does not work is also included in the resource supplement that was available for download.
Yeah.
Okay. Okay. You know what, Dr. Lachos, it looks like that's it. Well done. You got through them all. Thank you again. And as Patty mentioned, your evaluation will be popping up. I'm sorry. Go ahead, Dr. Lachos.
Oh, I just said I tried to answer about 10 or 12 through the text personally to each one of them too. They're very brief, but at least I wanted to get an answer to people.
Thank you for that, Dr. Lachos. Have a good evening, everyone, and thank you for participating.
Thank you. Bye-bye.